Okay, good afternoon. Hopefully everyone out there can hear me. My name is Dr. Tim Amrhein, and I'm coming to you from Duke University Medical Center for the Spinal CSF Leak Foundation's Ask the Expert session. I'd like to start by first wishing everyone a happy Leak Week. This is the first of three really excellent question and answer sessions this week, and I encourage you to join in tomorrow for the other two sessions, Dr. Shevink and Dr. Ian Carroll as well. These sessions are designed in an effort to raise awareness about spontaneous intracranial hypotension and CSF leaks and hopefully answer some questions. I should probably start by acknowledging our great team here at Duke and all the colleagues that I work with. In particular, we've got four great physicians that treat patients here. Dr. Linda Gray, who I'm sure everybody knows about, Dr. Peter Kranz, and Mike Malinzak, who's just recently joined our team. We also have Jeff Taylor, our superb PA, who helps us with nearly every one of our patients that come to Duke. We have an excellent support team in our office, most notably Amy and Charles, who really form the foundation of our practice and help things run smoothly. They're with me today, and they're going to be reading off your questions as we go. So during this session, we'll be answering questions as they come in, and they're going to be looking at your questions as they go. Amy and Charles will review them. They'll choose some questions for me, and they'll read them to me. And we'll try to get to as many as we can over the next 30 to 40 minutes. Please, let's have you keep your questions as general as you can and refrain from asking specific questions about your own medical condition, as those are probably best handled in the confines of a confidential doctor-patient relationship. Okay, so let's see if we've got any questions. I think while we're waiting for some questions to roll in, we can talk a little bit about maybe the scheduling process here, because I think that's one thing that comes up quite frequently. If there are patients out there that are interested in being seen by our team, the best way to reach out to us is to contact really Amy in the scheduling office, and that number is 919-684-7214, and you can get her on option 2. Okay. So guys, you let me know when we've got our first question.
I have a great question. A lot of people ask, how do you classify a slow leak versus a fast leak?
That's a really good question. That kind of gets to the underlying pathophysiology of CSF leaks. And so we first kind of have to understand what's going on. So you've got your brain and your spinal cord that are surrounded with CSF, and that's contained by the dura and other connective tissues that run down the spinal column. And when you have a tear in the dura, and when you stand upright, you can end up having leakage of CSF through that hole. The size of the hole likely relates to how much fluid is coming out at any one time. So there are different subtypes of leaks where you can get leaks that occur adjacent to nerve root sleeves within the spine. Those can be either high or low flow leaks depending on the size of the hole. You can also get leaks that arise from the ventral dural surface, which means kind of the front closer to the discs. Those tend to be higher flow leaks. So essentially what we're talking about is how fast the fluid escapes from the place that it's supposed to be. And really the best way to figure that out is through imaging. And they have certain characteristic appearances. The kind of go-to test that we use here to start is the CT myelogram at Duke, and then there are some secondary options that we'll use to assess the leak based on what we find on that.
Dr. Amrhein, another question that we received was how to best diagnose a CSF-related fistula.
Yeah, so I think probably the best thing to do here is just to stop for a minute and talk about the different types of leaks or CSF volume pathology, pathophysiologies that we've got. And so over time, we've sort of recognized a few other things. Originally, people thought that these leaks were coming just from nerve root sleeve diverticula. And so what does that mean? Well, at every level in our spine, we've got a right-sided and a left-sided nerve root that comes out. And basically what that allows us to do is to feel things and move our arms and legs and basically control our body. Along each of those nerves is a sleeve of connective tissue, including the dura. And you can sometimes have a ballooning of that dura around the nerve. That can be normal, and that is called a perineural cyst. Now, I probably have some of those, and we see those in normal patients who don't have CSF leaks. However, there are incidences where you have diverticula, so you have actually the stronger covering, the dura, opens up, and some weaker covering underneath, the arachnoid pooches through, that can tear, leading to a leak. And so one of the origins of leaks is from the nerve root sleeve diverticula. So that's one subtype of leaks. And so, that type of leak was originally the type of leak that we thought everybody had. But it turns out there are other causes of leaks as well. One that we now know occurs quite commonly is due to a disc bulge or a tear of the ventral dura due to a disc bulge in the spine. And those are high flow leaks. More recently, Dr. Shevink and his group identified the CSF to venous fistula. And so those actually are pathologic connections between those nerve root sleeves and an adjacent vein. And that allows for unchecked flow of CSF directly back into your circulatory system or your bloodstream. And so you get rapid egress of CSF out of the normal space that it's supposed to be, and that leads to that low volume state. So identifying those are actually something that's an active area of research and interest to pretty much everybody who treats these patients. They can be difficult to identify. They have a characteristic appearance on the CT myelogram, but the CT myelogram is not always positive for identifying them. So we're in the process through research of trying to figure out better ways to identify these fistulas. The team at Cedars-Sinai does general anesthesia and dynamic myelography. We've started to do some of that as well here, not under general anesthesia, but we do some dynamic myelograms as well. And there may be some utility in doing other types of imaging tests where patients are either laying on their left or their right side to try to identify the fistula.
Okay, here's another good question that a lot of patients ask. If you have a normal brain MRI, can you still have a leak?
Yes, actually that's a really good question. So another question I guess that goes along with that is, why do you need to get a brain MRI in the first place? And we come from, the way that we are approaching this pathology and this group of patients is from the standpoint of radiologists who are imaging specialists, and in particular neuroradiologists, so we specialize in brain and spine imaging. And so one of the first ways that some patients are recognized is through some characteristic appearances on the MRI of the brain. And basically what we end up seeing is brain sagging. So when you lose CSF volume and you stand up in particular, you have brain sagging. It comes down because of gravity. There's something called the Monro-Kelly hypothesis, which the simplistic version of that is that in your head, which is a fixed, the skull is a fixed space, you've got brain, CSF, and blood. And so if you reduce CSF, since there's a fixed volume, one of those other two things needs to change. And so what ends up changing usually is the blood increases in your head. So you get engorgement of the venous structures. And so that's what we see on the MRI of the brain in some patients. We'll see enhancement of the dura, so it's called pachymeningeal enhancement. And we'll also see enlargement of the venous system, the venous distension sign, as well as sagging of the brain. And so there's about, about a couple of different signs, and there's more and more being published every year in order to identify CSF leak. Now, we looked at a series of patients that we know had CSF leaks and went back and looked at their MRIs of the brain, and we found that actually about 20% of patients who had known CSF leaks actually did not have a positive MRI of the brain. So it's not 100% sensitive, but it's good to start with that test because we can identify some patients in that respect, but you can have a negative brain MRI and still have a CSF leak.
Next question. Jessica Richter is asking, when patching and leak site is unknown, what is the best protocol or guideline to follow?
Okay, so I guess the question there is, if we think you have a leak but we can't identify the CSF leak, I assume that's kind of what we mean by that. We don't know exactly where the leak is. Those are, challenging people to take care of because, we think that, the blood patching and the surgical procedures really do better, obviously, if we know where the source of the CSF leak is. So if we don't know where it is, we usually start with a CT myelogram in order to look for it. If we can't find it, then we may try other different imaging modalities, in particular decubitus myelography or sometimes dynamic myelography, where we're just doing different imaging methods in order to try to identify the leak. That is actually an area of fairly active research for a lot of people. There are other groups that are trying positive pressure myelograms where you're trying to increase the pressure of that space and see if that can kind of bring out a leak. So I think that's an area of active investigation, and hopefully we'll have some more answers as time moves on moving forward.
Are there any improvements in imaging being developed to detect slower leaks as well as non-invasive ways to determine intracranial pressure? And this is coming from Carol.
Yeah, that's a really good question. That is an area of active research. There's a couple of studies that we're doing here at Duke. one that my colleague Dr. Kranz is running, where we're looking at a couple of different imaging sequences to determine whether or not we can use imaging to come up with a better idea of what your pressure is without having to place a needle there. And so I think the short answer to that question is yes. I don't think any of those are sort of game ready yet. I think that they're still in the experimental and research phase, but these are all parts of things that need to be discovered over the next couple of years to decade.
How long does rebound high pressure last for most people after a blood patch?
That's a really good question, and the answer is it depends on the person. You know, rebound intracranial hypertension or rebound high pressure occurs in only a subset of patients who are patched. And we don't 100% know why it occurs, but we have some pretty good suspicions. For patients who have a CSF leak, there are presumably some compensatory mechanisms that our body has to try to increase that volume or increase that pressure. And one of the things that we've noted is that the veins around the dura in the epidural space engorge. They get larger when you've got a CSF leak in a lot of cases. And so there may be compensatory mechanisms like that and other things, perhaps increased production of CSF, that our bodies are doing in order to increase the pressure and the volume. And so when we patch a patient, no one sends a memo to your body to let them know that you're about to be patched. And so in that scenario, you can swing in the other direction, and you go from having low volume and low pressure to high volume or high pressure, and that's that rebound intracranial hypertension. In some patients, this is only mild or minor, doesn't require any intervention, and some other people it can be more severe. I'd say it probably happens to some effect in about 30 to 40% of patients with a CSF leak, and it's really only severe in a small minority of patients. And then as to directly answering your question about how long it lasts, it's variable. For most people, it's only a couple of days, but there are some people where it will last longer, on the order of a week or two, and we really just don't know. We can often manage it with medication, and only very rarely does something more than that need to be done.
Dr. Amrhein, Mary would like you to speak to Chiari malformations and how they factor into CSF leaks.
Right, so that's a really good question. You know, one of the things that is a bit of a problem out there is that there is sometimes misdiagnosis for spontaneous intracranial hypotension, and it's sometimes confused for a Chiari 1 malformation. So a Chiari 1 malformation is really a problem of the container, is the best way to think about it. And so effectively what we've got is a small posterior fossa. So the back of your head or your skull is smaller than it needs to be to hold the contents there, including the cerebellum and the rest of your brain. And so you get downward translocation of the cerebellar tonsils. And so that looks a lot like, to some degrees, a spontaneous intracranial hypertension or CSF leak where you've got sagging of the brain. However, on imaging, there are some telltale differences between the two. And in particular, the bottom or the floor of the third ventricle on a sagittal image is normally upsloping in a patient with a Chiari malformation, and it's downsloping in a patient with a CSF leak when the brain MRI is positive. And there's a few other signs too. So I think raising awareness between the differences between these two entities is really important. We've had many patients that have come here at Duke that have had suboccipital craniectomies, which is the treatment for the Chiari 1 malformation, where they've removed the back of the skull. And unfortunately, their problem was a CSF leak, so they didn't get better after that intervention. So I think, you know, that's one of our goals, is to sort of raise awareness about the confusion between those two things and some of the myths about SIH that are out there.
Next question. Why would a leak show up on an MRI and not a CT myelogram?
That's a good question. There's a couple of different ways to do the MRI. And so, you know, some centers advocate for doing a non-contrasted, normal, standard MRI of the total spine in order to look for a CSF leak before you move to an interventional procedure like a myelogram. We don't usually do that at Duke, but I think that there's a good argument for taking that approach. On those types of MRIs, you're not putting contrast into the space where the CSF is, so you're not looking for it to leak out. What you're actually looking for is a big fluid collection that has escaped from the normal location and into the epidural space or into the space surrounding the dura, indicating that there's a leak. That study is really useful for basically identifying a high flow leak. But it doesn't help us very well in terms of identifying the location of the CSF leak. So we need to do further studies if we do find that on an MRI. a non-contrasted MRI. There are other types of MRIs where we actually take MRI contrast and put it into the space where the CSF is in order to try to identify low flow leaks, and there is some literature out there advocating that. That is actually an off-label use of the gadolinium, and there's some minor risks associated with that in theory. We've not had any complications with those patients, but we do always warn patients about that. That particular type of procedure is thought to be better at identifying slow flow leaks, so these leaks that are weeping around diverticula, and so that might be one reason why your doctor might choose to go that route in order to identify a slow flow leak. And so in some respects, these different imaging modalities can be complementary in order to identify leaks. Here at Duke, we think the CT myelogram is the best first test and probably the most sensitive test for identifying a leak. So we start there, and we only use the other ones as an adjunct when necessary to try and identify a leak.
Dr. Amrhein, Laura would like to know if a long-term CSF leak can cause cognitive difficulties.
Yes. Yeah, one of the common complaints that we get from patients who have had CSF leaks or have active CSF leaks are cognitive complaints. And people often describe, and you can probably find it on the support groups as well, cognitive slowing or kind of a mental fog, difficulty with memory, sometimes word finding difficulties, and a few other things like that. So absolutely, even short-term and acute leaks can cause cognitive challenges, and we have seen patients with pretty profound cognitive difficulties after having a prolonged CSF leak. So I think the short answer to that question is absolutely.
Okay, we have a question here. A patient wants to know, or a viewer wants to know, is can a myelogram cause another leak, therefore compounding a CSF leak problem?
I see. Yeah, that's a common worry that patients have, and I can completely understand that. In order to do the myelogram, you have to understand that we need to put a needle into the space where the CSF is to put the contrast in there, because that's what a myelogram is. You get your needle access into the space where the CSF is, and then you put this contrast in that looks white to us on the imaging, on the CT scan in particular, and you look to see where that contrast has leaked out. So that's what a myelogram is. And so some patients are worried that placing that needle can lead to another leak, and I think that is certainly a concern that I can understand why you would have. What we do, I think the incidence, first of all, of an iatrogenic leak after a lumbar puncture is typically pretty low. There are lots of lumbar punctures that are done, and when done with care and under imaging guidance, I think the chances of that leak occurring are quite low. The other thing that we do here at Duke to reduce the chances of that happening is we use an atraumatic needle. It's called this Gertie Marks needle. It's a smaller, tinier needle with a pencil tip. That has been shown in the literature to reduce the incidence of post-lumbar puncture CSF leaks. And we do that because we don't want to have any question about where the leak is coming from. And we'll often, if we then move on to patching a patient, we'll often also patch over that leak site to ensure that that is not a possibility. I think to answer that question, I think theoretically, yes, we could potentially lead to another leak, but I wouldn't allay everybody's fears. I actually don't remember having had a patient where that's happened, and so I think that was exceedingly rare, and I think that going through with that procedure is, one, necessary to try and find the leak and is important toward getting you back to being better.
Kara would like to know if you've had improvement from a targeted patch but still exhibit mild low pressure symptoms several weeks later. Is it dangerous to not pursue another patch?
Yeah, that's a tough one to answer. I think that the danger factor probably is based upon your symptoms, and so I think if you're doing quite well and you still have a low level of symptoms, you may have a partial patch that might require repeating the patch. The way I usually counsel my patients in that situation is we sort of have a discussion, and it's a discussion between how well are you doing in terms of living your life, and what level of disability do you have, and how much symptoms you're having that are causing you discomfort. And if it's not worth going through another procedure and the potential risks of those procedures, then sometimes that's adequate for people. But I don't think that there's any intrinsic danger to having those low-lying symptoms unless your symptoms worsen, at which point you could, of course, come back for another patch.
Okay. Norma is asking, is it found to be helpful to be in Trendelenburg position following a blood patch? And do you do this post-blood patch at Duke, and if so, for how long?
Yeah, so we don't require that our patients are in Trendelenburg positioning, and so for those of you out there that don't know what that is, it's basically when you tilt the head all the way down and the feet up. So no, we don't require that our patients go into Trendelenburg positioning, but we do ask that people lay flat for about 24 hours afterwards in order for the patch to set. So effectively, what we're doing when we do a patch is covering over the hole, causing a reaction that leads to sort of a fibrosis and a sealing of the potential hole in the dura. And we think that laying flat helps to allow that to seal. Now, the reality is that none of us have really good evidence to support that theory. So everything is anecdotal. We don't have any research to show that having people lay flat after a patch leads to them having better outcomes than not laying flat. But anecdotally, over the years, I think all of us who treat these patients have realized that if we don't keep people flat, a lot of times the patches fail. So here at Duke, what we do is we plan to keep you flat for about 24 hours, and then afterwards we slowly get you up, usually over the course of the next 12 hours. And then we have some restrictions afterwards. So if the patch is working, we ask that you not lift anything heavy for about the next month. And then each of the different physicians does different things, but we then usually have some restrictions moving forward in terms of twisting activities and other things like that that could potentially tear a successful patch. So the answer is no, we don't do Trendelenburg positioning, but I think the concept is the same. We want you to lay flat afterwards to give us the best chance of success.
Jessica would like to know, is it better to try a non-targeted blood patch in someone with strong leak symptoms and risk factors for a leak before doing a more invasive imaging or traveling for perhaps something like what we would offer here at Duke?
Yeah, short answer is, and that's a great question, short answer is we have no idea. We don't know. And I think is really an important question that needs to be answered. And the way that we would answer that would require a prospective randomized clinical trial, which has not been done yet. And so, what we would need to do is we would need to take patients who have CSF leaks or symptoms that we think are concerning for a CSF leak, right? And then we'd have to randomize them to either getting that non-targeted patch versus the targeted patch where we put the needle directly next to a CSF leak. And what I would say about that so far is that I think that, yes, there are risks to any procedure, but if you're not anywhere near Duke and you have a local physician that is comfortable trying non-targeted blood patches, that's often successful, and I think it's very reasonable to start there. In the scenario where that's not successful, then you may want to reach out to one of the centers where people are treating these patients, including here, Cedars-Sinai, Stanford, Mayo Clinic, those sorts of places, to see if you can get somebody with a little bit more knowledge and ability to handle these targeted patches. I think I'll take this opportunity to say that we have started the first ever clinical trial here at Duke for patching, and so that trial is underway, and the goal of that trial is to enroll patients who have known CSF leaks. So we have to see a CSF leak on your myelogram, and then if you meet criteria for the trial, the goal is to show that this does work, and I think that there are some particular reasons why we want to do that. I think it's going to form the foundation for bigger clinical trials like the one I just proposed, and also will allow for, one, greater awareness, and two, reduce issues with some of the insurance companies moving forward in terms of covering these procedures.
So we have several questions about cisternograms, and when would we do a cisternagram, and what benefits are there, if any?
Yeah, so that gets to the source of where these CSF leaks occur in the setting of spontaneous intracranial hypotension. And what you'll find if you watch some of the other videos by Dr. Shevink and other people is that basically these leaks don't really occur from the skull base. And so what a cisternagram is you put contrast into the head. So you can do that from a couple of different approaches, but the most common way to do that is to do a lumbar puncture. So you put a needle in the lower back, and then you dump contrast up into the patient's head, and you do a scan, and you look to see where the contrast is leaking out. Now, there are other versions of that. There's a nuclear medicine cisternagram. I'm not sure if that's what the point of that question was, so I can talk about that in a minute. But essentially, usually the cisternagram is to look for a CSF leak that's coming from the skull base. Now, skull-based CSF leaks do not cause headaches, or positional headaches in particular, and they don't cause the symptoms that spontaneous intracranial hypotension patients have. And the reason for that is because when we stand up, we actually have negative pressure in our head. So we don't actively leak when we stand up. from a skull-base leak. In fact, what happens instead is that you have reduced pressure, so your leak stops. So patients who have a CSF leak arising from the skull base tend to report that they're getting fluid dripping from the nose or the ears. That tends to be worse when they're bending over, even putting their head between their knees. That's when they'll get this gush of fluid. And so those are the types of patients where a cisternagram is probably more indicated. Patients who have leaks coming from the spine, which are the SIH patients, report positional headaches that are worse when they stand up and better when they lay down. And that's because when you stand up, gravity pulls the fluid down toward the leak and you get more leaking. And that's the basics of that principle behind it. I'll take a moment to talk briefly about the nuclear medicine cisternagram, which is another imaging test that was used in the past at places to look for CSF leak, and I think it's still used out there. That is a radiology test where they actually take a radionuclide, so it's a radioactive, let's call it a particle for simplicity purposes, and they put it through the needle in the lumbar puncture and then look to see where that particle leaks out and then look at the counts of radioactivity and see where it goes. It's a well-established procedure that's used for a lot of different things in medicine besides CSF leaks. We don't use that here at Duke, and the reason for that is because the resolution, which means the finer detail on that imaging test, is much less on that than it is for CT myelograms or even MRI, and certainly compared to the dynamic myelograms and digital subtraction myelograms that we do to look for these little small leaks. So the nuclear medicine study lacks both the temporal and spatial resolution that I think is required to really identify these leaks, and there's a few other things that lead to false positives on that study that we have found it not to be helpful, so we don't do it here at Duke.
Dr. Amrhein, Nisha is asking, what are symptoms of a CSF leak?
Okay, that's a really good and basic question. The problem with that is that they are pretty varied, and you can get lots of different symptoms after a CSF leak. And that can make it really challenging. It can make it a diagnostic challenge. The hallmark or principal thing that neurologists and other primary care physicians look for in the setting of a CSF leak is a positional headache. And so what does that mean? That means a headache that's worse when you're standing up and better when you're laying down. And so that's the most common report that we get from patients who have CSF leaks. Now, not every patient with a CSF leak has a positional headache, and it seems that the longer you have symptoms, the less likely you are to have that positional headache. The other symptoms that people with CSF leaks can have relate to really the cranial nerves. And so when you get brain sagging, you get tugging on the cranial nerves. And so those are the nerves that go to your eyes and your ears in particular, but also to other areas of your body. And so people will report, they'll report double vision, they'll report ringing in the ears, muffled hearing in the ears, and then some of the cognitive disturbances that we mentioned kind of earlier in this session. So there's really a myriad of different symptoms that patients with a CSF leak will present with. And for that reason, they will often be sent from their primary care doctor to another subspecialist like an ENT doctor or a neurologist, or sometimes a surgeon, and those physicians are trained to look at one component of the picture, and for that reason sometimes misdiagnosis can happen. So putting all of this together is really important. Raising awareness about the different kind of spectrum of symptoms that patients can experience, I think is really key moving forward to help reduce the incidence of misdiagnosis and get people kind of where they need to be from the beginning.
Here's another good question. Can you explain the difference between the dynamic CT myelogram and the regular CT myelogram?
Yes. So what does dynamic mean? Dynamic just means quick, really. So the traditional myelogram, or CT myelogram, it was done previously for, most commonly was done for back pain or neck pain, where we were looking at possible need for surgical intervention for that. So completely different from CSF leaks. And so that's how that study was initially developed. And so what a myelogram is when we put the needle down there and we put X-ray dye in and we take pictures. The CT myelogram is we do that and then we put you on the CT scanner and we take pictures. So the traditional way of doing that is to do the needle in one room, put the contrast in there, and bring you over to the CAT scanner, and usually about 20 to 30 minutes later, we do the scan on a different CT scanner, and then we look for whatever we need to look for. The problem with that method of imaging during a CSF leak is if you have a high flow leak, the one where a lot of fluid is coming out, we can't tell where that leak came from. So all we know is that there's a leak at that point because all the contrast has spilled out everywhere, and we can't identify the source. So what the dynamic component is trying to do it quicker. And there's different versions of that are done at different places, and we're beginning to sort of improve upon that test every year. The way that we do it here at Duke is we actually do that lumbar puncture under CT fluoroscopic guidance. And so we use the CAT scanner to guide the needle tip location. That does two things for us. The first is it allows us to be sure that we're in the right location with no ambiguity. And so when we inject the contrast, we know we're in the right spot. The second thing is that when we put the contrast in there, we're able to scan you within a minute, and that is the dynamic part, the increased temporal or time resolution, where we can get those pictures right away to try and identify the source of the leak immediately, so we don't kind of miss the opportunity. There are other versions of that where we're trying to improve the temporal relationship, and that includes the dynamic myelogram where we're not using CT. And for that test, we actually don't use the CAT scanner. We use a fluoroscope, which is a traditional X-ray modality, where we're looking to see the moment where we run contrast over the spot where we're suspecting a leak and try to capture the minute when it leaks out. To do that test, we really kind of have to have a suspicion for a particular location so we can focus on that location. Hopefully that answers that question. So I think, guys, we are at 2:30, so why don't we do another 10 minutes or so, and then we'll wrap up, okay? Thanks so much so far. This has been really great questions. If anybody is just tuning in the interim, I'm Dr. Amrhein, Tim Amrhein from Duke University Medical Center, and we're doing our Ask the Expert live session as part of Leak Week here.
Is there any harm, or what is the risk to having multiple patches?
Yeah. And so I guess I can interpret that question two different ways. Multiple patches in the same procedure, or do we mean multiple subsequent procedures with multiple patches? And I guess the answer to that is actually the same in either scenario. I think really what the harm is only the potential risk of the procedure, really. And those are the standard risks that we get with any blood patch procedure, and they include bleeding, infection, and injury in structures when we're placing the needle on that location. For the most part, the risk profile for that procedure is actually pretty low, and certainly probably less than that from a surgery, because it's just a simple needle procedure. And then in terms of having multiple procedures, it would just be kind of the compounded risk of getting multiple procedures. The other thing to mention is the potential for rebound high pressure. So it really depends on a patient's individual situation. So if we know that you've got a CSF leak, then we might suspect a certain type of CSF leak, like a fistula, for instance, we might suspect that you could go into rebound high pressure. Sometimes we'll try patches in patients who we think they might have a CSF leak, but we don't see one on the myelogram. In that scenario, we might have rebound high pressure. And so that's another thing that we often counsel our patients on, is that that's another potential risk of doing a patch, is that you could end up in that rebound high pressure state, which can lead to an annoying headache that's different than the usual positional headache. It's typically worse when you're laying down and better than when you're standing up, so it's the opposite of the kind of traditional CSF leak headache.
Beth would like to know, for a chronic migraine patient who isn't responding to any traditional treatment but doesn't fit the typical CSF leak symptoms, is it still fair to try to rule out a CSF leak?
That's a good question, and one I think that requires probably more research moving forward. Chronic migraine, I think, affects 30 million people in the United States, and a CSF pressure pathology, in my opinion, and probably the estimation of all of my colleagues here at Duke, no doubt underlies probably some of those cases. And so I think it's very reasonable to consider or at least exclude CSF pathologies in certain cases. Bear in mind, if your MRI of the brain is negative, your pressure is normal, and you don't have any imaging of a CSF leak, any evidence of a CSF leak on imaging, I think the chances in that scenario that you actually have a CSF leak that's going to improve from a blood patch is probably pretty low. We will, in certain cases where those patients in that scenario where they have really suggestive symptoms, we might try a non-targeted patch. We can't do a targeted patch unless we see a leak, but we might try a non-targeted patch as a diagnostic tool to see how you respond to that and see if that's at all helpful. I think that's a very good question. It's a challenging question to answer, and I think that's something that we're going to try and move toward getting a better answer over the next decade or so.
So next question. Someone's asking about treatment for rebound high pressure, and can rebound high pressure blow a patch?
Yeah, good question. So first of all, with treatment, most of the time the rebound high pressure is not very severe. And so I want to just reiterate that rebound high pressure probably occurs in about 30% of patients who get patches, of which only about 20% of those, so we're talking a real subset of patients that get patches, actually get really significant rebound high pressure that requires treatment or intervention. For the most part, when you have rebound high pressure, there's not too much that needs to be done. Sometimes we will just give you some medication by mouth to help reduce the pressure. There are a couple of different medications that we use. The first line agent that we use is something called Diamox or cetazolamide, which is a medication that helps to reduce that pressure. Most people get by with just that intervention, and it's short-lived for a couple of days most often. If your pressure is really severe, on occasion, we will have to bring you back to the hospital and do another lumbar puncture and remove fluid. That's really pretty rare. We don't have to do that very often. There have been a few small subsets of patients where patients have had to be admitted to the hospital. But I think that the severity of rebound high pressure is uncommon. Did I answer that question? I think I got that. Yeah, okay.
Next question, can a non-targeted patch be done with fibrin glue, or does it need to be targeted to use the glue?
Yeah, so the fibrin glue, here at Duke, we use the fibrin glue solely for targeted patches. And I think there's a lot of good reasons for that. We wouldn't do, so if we found a leak, we're always targeting patches, doing targeted patches here. So we use CT fluoro-guided needle placement, which I think is kind of affords us to get the needle in places that I think you can't do very easily using other imaging methods. And so we elected to use that option. And we choose to use the fibrin glue in the setting of targeting for a couple of different reasons. One, it's not entirely without risk. It is a biologic, and so there are sometimes allergic reactions with it. It's really pretty rare, but we try not to use it unless we feel like it's really warranted. And the other thing is it's expensive, so that's another reason. Okay, guys, video number 2 here. Hopefully everybody can see me. Sorry about that technical difficulties there. Apparently my phone was overheating and it actually shut off. I didn't know that iPhones did that. So I think what we'll do is we'll wrap up at this point, and we will basically say goodbye. To answer the rest of that question, we usually just use fibrin glue for targeted patching. We don't use it for non-targeted patching. Our non-targeted patches are usually just done with routine kind of blood to start and see how patients respond. Well, to close out here, again, sorry for the technical difficulties there. I really enjoyed this session, enjoyed the opportunity to answer your questions. There were a lot of really great questions. Sorry we couldn't get to all of them. There's tons of questions in that short amount of time. I'd like to, again, thank Connie DeLine and the Foundation for the opportunity to do this, and thank all my colleagues out there at the other institutions for all their great research and efforts in taking care of these patients, and of course thank our amazing team, all the physicians, Dr. Kranz, Malinzak, and of course Dr. Gray, Jeff Taylor, our PA, and then Amy and Charles, of course, who are a big help at all times and especially today. Thanks also to our patients for being so great, and hang in there. We're going to keep working toward research and getting people better. Thanks so much. Bye, guys.